Now starting. All attendees are in listen-only mode.
Well, welcome everyone. I hope everyone's having a nice evening. I'm Dr. Guy Yatros.
I'm Dr. Richard Drake. Thanks for joining us on your Tuesday night. We're going to learn something about side effects, hopefully.
Yes, we are. Thanks everyone for joining us on this September 11th. We'd like to say, it's a memorable day for wrong reasons in our country, and I know a lot of you who maybe lost loved ones or had experiences 17 years ago today, and it's been with us all day, as well as the people on the East Coast that the hurricane's bearing down on. So it's hopefully we can get some education today, and also remember some days that weren't so pleasant. All right, so we're going to get started. I think this is the biggest concern, Rich, that we see when we talk to dentists and we educate dozens of dentists all over the country and talk to physicians and even some educated patients. Wow, these dental devices, this is what's going to happen to everybody that we make one of these for. Isn't that the perception that we get at some points?
Yeah, I actually did a lunch and learn for a dental office today, Guy, and I said, if you guys had just one question or a concern, what would it be? And they had 3 hygienists in this dental office, and all 3 said, man, we just heard they really mess up people's bites, and we just can't refer if it's going to mess their bite up. And I said, well, let me set you straight about that. But, this was a patient of mine, I believe, Guy, when we got this picture, and it was a patient that I made a device for, and she left, and she didn't come back for 3 years. And when she came back, and I said, kind of do that kind of, are you biting on your back teeth? Yeah. Are you? Your back teeth touching? I don't know. I think they are, aren't they?
You want to get your hand
out.
out.
That a sphincter factor of about 9.5, right? Yeah. But no, this happens very, very seldom, and if at all anymore, because of some of the things we're doing.
Yeah, I think that's the key. This is something that can happen, and it's going to bother you when it happens. But if you'll follow the protocols that we'll talk about today, and we do these AM aligners and we educate our patients, they're going to come in before it gets to this point. Not to say you're not going to have bite changes, but you're going to get. We're going to get to it first. So I think the key thing, I think, Rich, this slide here, the take home on this is that you're going to have patients who have some side effects, and for the most part, I honestly believe, I know, Rich, you believe the same as I do, that it tends to bother the dentist more than it does the patients in most cases, and we kind of tend to get the patients even more worked up about it. Go into this with the idea this is part of what happens. I mean, if every time you had to do any dental restorative procedure, it's going to freak you out if that patient's going to have some discomfort. I don't think we'd ever take the burr out to a tooth again, because yes, they may have a sensitive tooth when we're done. Yeah, they might have a beautiful crown. Tooth didn't hurt before, now it hurts. So, right? I mean, maybe that only happened to me as a dentist in dentistry.
Yeah,
but,
right.
So this is it's not as common, but it's a known side effects. These things we're going to talk about, and your demeanor, how you act, how you prepare the patient first for understanding that these things can happen, are critical to making you enjoy practicing dental sleep medicine, as well as your patients enjoy the treatment that you're going to provide for them. So if I can find the mouse, we'll move forward.
Because if I act very concerned, then you act concerned, and I think most of our patients trust us to do some of that stuff. It'd be like telling somebody they had cancer, and if you just did it anyway, that's probably not a good example. But the point is, we want to make we want to be confident and competent when we talk about this, and act like this kind of stuff can happen, and well, we just do it.
Yeah, and I think this piece of paper you see here with the informed consent, it's your best tool to manage this, but it's not because we have them sign this piece of paper. I mean, that's part of it. Yeah, we want them to legally accept these possibilities, and so we're covered in the rare event that it might become something of an issue. But mostly we want this informed consent because it's our job to talk to the patients about what can happen and what the benefits and risks and alternatives to treatment. And yeah, these things can happen. And so I think a lot of dentists see this informed consent and get nervous. Oh, I'm just going to have them sign that and not read it. And we go over some of the key things with our patients that we'll talk about today. And then there's other things that don't happen very often, so we probably don't key in on them. But if they have questions, we answer them. And we don't make excuses. We don't let it stress us. We don't, well, what's your concern with that? Let's talk about it. Because it's our job to let them understand these are risks. And we shouldn't be apologize or worry about it. We should just make sure that they get the message when it's all said and done. So,
well put. I do think your attitude makes a big difference, and we've talked about that, but I want to reiterate that. You know, it's just in how you present it, how you talk about it, and how you do it. And if you take one single thing away from this tonight, that's right. Probably the best thing you can take. It really is.
I don't think that any of the other things will matter if you're you and your team are freaked out about this and like this is this is unexpected, and if you hadn't discussed it with your patient. So a little bit of housekeeping. If you want CE for this, you'll get it within 72 hours. If you don't see it in your inbox, then look in your spam folder, because we'll be sending it to you. And if you don't see it then obviously contact us. Also, we're answering the questions. We have a whole team of dental sleep experts that work for DS3, and they're going to be answering questions as we go along. Rich and I will be typing in some answers. So if you have questions, type them in the question box. We have over pushing 400 people signed up for this tonight, so we can't open up everybody's mics. But if you'll put questions in, we'll answer them either type back or we will verbally answer them. So we'll stay until all the answers are there for you. So keep them coming. Rich, we've been doing this a while. I think that's maybe why we know all the things that could go wrong, because we've done thousands of these devices over the last pushing 40 years. So we've learned quite. We've
made a lot of mistakes on the way too. So that's how you learn stuff, isn't it?
Yes, it is. And what we do at DS3 is we help dentists succeed at dental sleep. And we'll talk a little bit more towards the end of this. If you want help in dental sleep, if you at any point, or if you even just want to know an answer to specific questions that maybe we don't have time for tonight, just type in consult, and we will schedule with one of our dental sleep expert trainers. They'll contact you. They'll answer your questions. They can talk to you about the challenges you have in your dental sleep office, and we can talk about how we can help that on an ongoing basis, because that's what we do. We have a whole team of experts that come to work every day to help offices succeed in dental sleep. Rich, this is exciting. You're about to get this course ready to go, right?
Yeah, we've been working on that a little bit, especially Jason, trying to put this together. So 25th that evening, and then all day the 26th and 22nd in Dallas. We're going to do an advanced course. So mostly Keith Thornton and I, Mark Fowler, will join us. There'll be a couple other people there as well. So we really get into the nitty gritty. Anybody can take that course, but I don't think you'd probably get as much out of it unless you'd at least done, I don't know, what do you think, Guy, 20, 30, 40 devices at least, something like that? So,
a dozen.
I mean, you're welcome. Yeah, you're welcome to join us, but those of you who have done this a little bit more, I promise you will learn something about that. It's kind of, what we're talking about here, Guy, it's just expanded for 2 days, where we talk about all the different challenges we face and how we deal with this type of patient or that type of patient. We get into, how to deal with some of the more complicated sleep apnea cases as well. So it should be a very good course.
It's a limited number as well. So if you want to go, get to spend several days with the master, Dr. Rich Drake himself, and Keith Thornton, inventor of the TAP. They're going to talk about how they do all the things from especially for the more complex cases and combination therapy. We do more courses intended for more beginning, introductory for team and dentists. We do those all over the country. We have courses coming up in St. Louis, Cleveland, Rochester. We have a symposium coming up. These courses that we do are 2-day hands-on courses. You get a sleep device for yourself or one of your team members. You get a sleep test that we go over and review. You get 14 hours of CE, and you leave there with everything you need to know to get started doing dental sleep. It's $9.95 for you and one team member. If you type in course tonight, you actually save $200, so it's only $7.95 for that. And then one last thing, and we'll get moving on. We'll be happy to review this with you at the end as well. Our symposium, and I do want to just stop and say this is rapidly becoming one of the biggest, if not probably the second biggest sleep meeting in the country. last year we almost sold out. This year we will certainly sell out. We're well above where we were the year before. We have a great lineup of speakers that speak for 1 hour, very important topics that are real practical for you to do in your offices. The room right here in Clearwater, Florida in February, which I think will probably be more decent weather than most places in the country, is $250 a night. I know those sold out last year. And then this year, I think Jason just told me that we put out a flash sale. If you type in Flash 100, that's all in one. If you put that in as a code, when you go to register, you save $100 for the dentist. And it's the last time we're planning on doing that because we're projected to sell out because we're far ahead of where we were the year before. So if you want to save that, that $100 is approaching the last time that you'll be able to do that. Rich, anything else to add on? I mean, I think the symposium is one of the things I'm most proud that we do.
It's going to be good. Hopefully you can make it. Great time to be in South Florida too. Florida.
Yeah, and we'll mention this at the end too, but next webinar will be October 9th, and we'll be doing out-of-network medical billing. And I tell you, between managing side effects and billing are typically our two biggest attended webinars. So, and this is going to be some different information than the general medical billing. We're going to get more specific about different ways to navigate the out-of-network billing because most of the dentists we work with are. So let's get back to the side effects, Rich. I think this is when you drove my boat up here on the upper right. Isn't that what happened last time I let you?
It makes you wonder how that stuff happens, doesn't it?
I mean, you know, this is all things that can go wrong, and that's what we're going to talk about. Actually, this was given to me by a patient as a physician that said that the patient came in with his chief complaint of had a sore throat, and by the way, I can't find my partial. So I think the reason, and that's a true story. So I think the point there being side effects happen. What's the dentist, Dr. Lowe? Get over it. How does he say it, Rich? If you go to the
get over it. Side effects happen. They happen with everything. You know, there was a comment earlier, guy in the questions. I don't know if you saw it about, well, isn't this just like oral surgery or, you know, or ortho or, you know, endo or anything else we do? Sure, we have people sign informed consents, and you don't fret over a broken root tip anymore. If you take out a lot of teeth, you just talk about it like it was nothing. So you need to act the same with this. But, you know, these are, this is an exhaustive list. You know, there's really just a few that happen, you know, pretty routinely, but, you know, any of these can happen. All of the device manufacturers out there have informed consents, Guy. We have them built into DS3 as well. They're pretty easy ways to get them if you don't have them already.
Right, and we'll talk about the more commons of these because this is, I think we keep emphasizing it's not just protecting yourself legally. We want our dentists we train to enjoy providing the service to their patients, and part of that is being prepared for these side effects and having the conversations prior to maybe experiencing this with our patients. So I would say the most common ones we have on here are some sort of T&D jaw pain. We'll talk specifically about those a little bit. Tooth soreness, I would say, is probably the most common side effect. I mean, people get a little tooth soreness almost always when we give them the device for a day or two, and we let our patients know to expect that. And then the one I think that bothers the dentist the most are tooth movement and bite changes. So I always mention these three to my patients out loud verbally in addition to going through the informed consent, and then we may talk about some other things that may more specifically pertain to that particular patient. So here's some other things that we can look at, Rich. Too much saliva. I had one of our members contact me today about that one, or too little saliva. So there's a lot of different things that we can get into here. I think we'll just get into the more details so that we can talk about how we manage this. So this one happens.
That was the first contact that came up tonight. I mean, that was the first question that came up tonight, Guy. Was how do you deal with this?
All right, well, let's talk about it. This is, I would say, one of the more common side effects, but it's also one of the more preventable. Wouldn't you say so, Rich, depending on the device design? Yeah.
Yes, I would. And we call that, you know, the first bite of beef jerky you take. That's where it all goes, right between those two teeth. You know, those of us that have a couple of open contacts that can really appreciate, you know, when we chew stuff like that or a ham sandwich or something, and that stuff gets stuck in there. So you know, what's happening here? You know, I think there's a couple of things that can be causing this, you know, as we look at it. you know, a lot of times, we can be moving the entire lower teeth forward and the upper teeth back just a little bit. But there's a couple other things that can cause that as well.
Yeah, and I think what we really want to think about is how we can prevent it. So one common cause of this is ball clasp. If you have the certain devices have the ball clasp, I'm not saying don't do the ball clasp, but if you're going to put a ball clasp between two molars or premolars, you need to make sure that the acrylic wraps around the most distal part of the molar. So a recipe for this happening almost always is you have a ball clasp between a first and second molar, and then the acrylic doesn't wrap around the distal of the last molar, and then it just separates the teeth. Other things that the flexible materials that we use, which we find the patients often like for comfort, and there's other reasons we use those, we lose a little bit of control over holding the teeth together. So using a device that has more of a hard acrylic around it so that it prevents this tooth movements is a great way to prevent these. If you really have great contact around them, you wrap the teeth on the distal, you titrate them slowly, you're not going to see this that often. I used to see it a lot when I first started doing dental sleep because I didn't know to not do those things. Any other things I'm forgetting, Rich?
No, and I think if we want to get device specific, if somebody has third molars, before you even ask that question, do we wrap the third molar? Very, very seldom do we wrap the distal of a third molar. Why? Depending on the curvus B and Wilson and how much these things are, we got to open a little bit to move forward. And if we got to wrap the distal, now I've got 2 millimeters thick of acrylic on the third molar, and that means I got to be open, 14 millimeters in the front. So you always have to kind of weigh the pros and cons of these types of things, as we do this. We like to say, guy, you got to use your brain, right, when you think about this and you do it. But I will say that a ball clasp is probably the biggest reason that this happens. And some of you will say, well, how do you get a device to stay in if they have very short teeth? That can be a challenge. I would say use thermocryl. You can get thermocryl and heat it up. Even with short, fat, straight teeth, you can still get pretty good retention without having to use ball clasp. But I do think, Guy, sometimes it's better to use ball clasp and treat sleep apnea than be unable to have a dental device in.
Right, and to be clear, a lot of the devices we work with do have ball clasp, but just make sure you can wrap the distal of the tooth. So that third molar case you're talking about, maybe we'd go with thermocryl or some other hard acrylic that doesn't, and because we can't get, a lot of times you can't even get the impression material behind the third molar because there's tissue over it, and I'm not going to get the laser out, cut the tissue away to help prevent this. So like Rich said, using your brains a little bit. So a hard acrylic and wrapping the distals are really the key if you want to avoid the open contacts, but there's times where ball clasps are by far the preferable choice, and let's make sure we keep in those design features in mind when we use them. Posterior open bite, I'd say this is the one, I wouldn't say it's the most common by any stretch of the imagination, but it's the one that really, as you said, gets the dental offices all kind of freaked out. And I'm not minimizing that this is something that we just say, oh, it's no big deal. But that being said, Rich, I bet I have at least pushing 100 patients, at least somewhere between 50 and 100 patients who've been functioning like this for years, and they are still obese. They still are eating okay. They say, yeah, it's a little harder to chew this, and they're not breaking their teeth down. So we could talk about occlusion and a lot of other things on a different night, but understand a person with this posterior open bite that's alive is better than one that has perfect occlusion in the grave, which sleep apnea can lead to death. So in certain cases, so we don't want to see this, and we can prevent it, or at least monitor it if we understand what causes it. And I think this picture, and everything on here on the screen. What I gather from that is a lot of things can cause this posterior open bite. It's probably not one thing always. Would you agree, Rich?
Yeah, and what's so hard for dentists to get through their head about this, guy, is it doesn't bother the patient. It's like as a dentist we go, oh my gosh, You know, when you think about the jaw opens and moves forward, as the jaw moves forward, it kind of counter rotates a little bit. So that depends on the articular eminence and how steep that plane is as we move our jaw and how far we move our jaw and all this other stuff. So like I said, there's a lot of reasons. A little bit of it, I think, is edema, you know, especially early on. That's one of the reasons we titrate slowly. But, you know, this study was, the teeth aren't intruding. You know, it's really a repositioning of the condyle within the fossa. So when we see people like this, that patient really, Guy, it was really, you know, can you make your back teeth touch? And she kept biting like that. And she goes, well, are they not touching? You know, she didn't even know, like you said.
Right.
And like you said, they're still obese and they're all that other stuff. So does this go away? I would say 99 times out of 100 it has. So the first thing we want to do is try to avoid it. And the best thing we can do to avoid it is simply recapture the bite every day. So we open, we move out here to treat, and we go back. We call it ground zero, Guy. We go back to zero. Open and treat, go back to zero. Open, go back to zero. I need you to go back to zero every day. The first day you don't go back to zero, that's the beginning of your bite starting to change.
Right.
Okay. It's not any more complicated than that. That's exactly how I say it to patients.
And there's a lot of ways to accomplish that. You can see them listed here on the screen. We've done all of these and continue to do some of these over time, chin push exercises. But like Rich said, we want them to go back to ground zero. The way, I think the next slide coming up, this is the way that we do it primarily, and we have a little different technique from this exact picture, but we basically make a repositioner. The AM aligner from Airway Metrics is one of my favorite ways of doing it. You can do a full arch or canine to canine. I prefer the canine to canine in most patients, and you heat this material up, turns into bubble gum. When it gets hard, it becomes pretty hard. Quite hard. And what it does, it makes a repositioning jig, I think, for lack of a better word, the patient bites into every morning after they take their device out. And what that does, Rich, I think is important, is helping guide their jaw back. We train them to pay attention to their bite. Bite down on this. I want you to feel your back teeth coming together. I want you to feel that your jaw seating. We want to kind of squeeze that edema out of your joint and give it a second. So you squeeze and release. Then they take it out and they bite down and they evaluate their bite. So if they follow those instructions, they shouldn't go more than one day with the bite that's off if they're evaluating their bite every day. Now, I'm not to say every patient does everything we ask, including flossing and a lot of things that we want them to do, but most patients who will follow this protocol, as Rich said, we can most likely prevent this bite change, because at that point, if they've changes after one day, they can continue to reposition, take a night off or so, and we get the jaw to go back. So it's not as big of an issue as it used to be if we follow these protocols. Rich, do we want to briefly talk about what we do once it happens if they have the posterior open bite? I don't want that could be a long tough topic, but I think we should at least address what happens at that point. I'll go back.
I mean, very simply, Guy, we tell people, can you wear CPAP? Can you tolerate CPAP? Yeah, I guess I could if I had to, or I have one, I haven't taken it out of the closet in a while. We want you to, take it out, put the CPAP on, and we want you to really work at doing that. One of the things I got to move my microphone a little bit, but if I put my fingers right here and I put my thumbs underneath, about halfway back on my jaw, and I'm pushing back with my fingers this way, and I'm pushing up with my thumbs like that, I'm kind of trying to rotate my jaw back in place. And we tell people, I want you doing that right there. If they still have an AM aligner that was at zero, we have them do that too, for a minute at least 10 times a day. So we tell them every time you sit on the toilet, every time you're stopped at a stoplight. But if they can't wear CPAP while they're doing that and they're still wearing their dental device, it takes a lot longer. But we have had people work at it, and it took that one lady 6 months, but she did finally recapture her bite.
Yeah, I think that's the key. We talked to them about whether they can go without the dental device. What does that mean? Treatment alternatives. And like you said, most of the time it'll go back. The longer it's been off, the less likelihood it'll go back in my experience. But getting them to reposition, we use one called a chin push, where we actually have them on the, I don't know if you can see it, but have like this, and have them sit on the table and have them lean into their chin, doing the same thing with the table under the chin, and get it to go back. So if you want more information on that, we don't want to take the whole webinar on that particular subject, but we have protocols for what to do when it happens, but we don't have to get into those protocols nearly as much. And if we do, the patient usually comes in, yeah, I know, I kind of noticed the difference. I haven't been doing what I was supposed to be doing every morning, at least with the responsibility shifted a little bit in the patient's direction. So, all right, over long term, I think, Rich, you already kind of talked about what happens with these forces, but you want to touch on that once more?
Yeah, well, the simple physics guy, I got, go back to high school physics. I got my upper teeth, my lower teeth. And when I open and move my jaw forward, and then I lay down, doesn't matter if I'm on my back or my side, what does my jaw want to do? My jaw wants to, do that, wants to fall down and back. So the simple force vectors are pushing back on the top teeth, and they're pushing forward on the lower teeth. So that does all of these things exactly like we're talking about. It opens posterior bite, it moves the teeth this way and that way with the overbite and overjet. So again, a lot of this is the AM aligner. If we just work to recapture that bite each day, it really does make a difference. And we haven't got this question yet, Guy, but somebody said, well, if they start out a real class 2 like that, and we move them here and here, can we charge for ortho also?
I don't know about charging for it, but that is a good point. People who are largely class 2, you can look at them in the eye and say the odds of you having a negative major bite change is much less than most people, because if they have a bite change, it's going to be a positive bite change. So changing the bite's not always negative. So orthodontists change the bite all the time, and we might in fact make a bite change that's actually positive for that particular patient, and it does happen as well. So salivary flow, I'd say one of the more common side effects. Initially, people will get an increase in saliva a lot of times, and then later on, the dry mouth can happen. Sometimes dry mouth will start sooner, and it can be bothersome. It's not something that's going to prevent someone from wearing their device unless it's really severe. The increase in salivary flow most of the time goes away. But as I mentioned, one of our original franchisee offices sent me that question today. They have someone 2 months later that still has a little excess saliva. Rich, I'm interested in your opinion on this, but my opinion on that is because we swallow all night long. We produce saliva. It's a normal part of what we do. And likely in that case, the device is preventing them from swallowing normally. And if maybe it's got some acrylic down too far on the lingual, maybe they can't get their lips sealed. And if that device is not allowing them to swallow at night, then the patient's waking up with it on their pillow. So my advice, if it goes long term, try to evaluate their swallowing and see if there's anything you can modify on the device, but also let the patient know this is a side effect, that, hey, you're breathing well at night, so you got a little saliva on your pillow. Which would you rather have, breathing or saliva, and let them decide. Any other advice on the increased saliva?
No, that's good. One thing we do, Guy, is did you have that problem before you had a dental device? Oh, yeah, I've always had that problem. Okay, well, it's probably not going to get any better with a dental device. But I like the cup of water on your nightstand. Before you go to bed, you take a sip. Every time you wake up and go to the bathroom, you take a sip.
This is for dry mouth.
Part of that is you're learning. Yeah. No, even for too much saliva.
Oh, gotcha. Okay.
Because, well, it's for both, actually, because, we used to just do it for dry mouth, but I had a lady one time that was salivating a lot, and she said, I think that really helped me learn how to swallow better with that device in my mouth. So I do think that closing the vertical a little bit, allowing them to get lip closure, it's very hard to swallow.
Yeah.
With your lips open like that. So again, talk about it, look at it. I would say the bigger problem, though, is probably dry mouth, and it's for a lot of the same reasons. If somebody's class 2 deep bite, and I'm going to put them in a tap or a dorsal or a Herbst, it doesn't make any difference, prosomnus, whatever. I got to open them this far. Then I have the acrylic. Now I can move them forward. So a deep bite class 2 always has much more trouble getting lip closure. So those people, again, this using your brain, we would say, hey, look, you might have a problem with too much saliva and then too little saliva. Here's some things you can do. The cup of water, the biotin, they make the little trokes and things like that you can put on your cheek and do all that kind of stuff. All of those things help a little bit.
Yeah, and the last thing I have on there is advancement, because the dry mouth can sometimes be that the patient's still breathing like that at night, and if we get them more advanced and they get more volume of air moving slower, that I found that to be helpful. And again, keeping the mouth shut with elastics and lip seal. I think we've covered that one. Side effects, tooth pain. Sometimes I think, well, geez, dentists should be able to figure this out, but I realize maybe it's different than the vectors that they're normally looking at. So, I mean, you know how to adjust a night guard, you know how to adjust partials. So as Rich said, you got to use your brain a little bit. But I think one thing that maybe is not apparent to at the very beginning is it could be that the device is causing this, or it could be that when they take the device out, that their bite is now causing this because their bite is changed.
That's a good point.
And I think that's where sometimes we get confused because we're fiddling with the device. So the first thing really to evaluate is, does it hurt? When is it hurting? Is it hurting with the device in? No, it doesn't hurt until the next morning about the time I'm having breakfast. Well, it could be that. And it also could be the repositioner putting the force on it. So figuring out what's causing the force by asking questions about when is it hurting. Then if it is the device, which is the most common, where does it hurt? And they'll tell you, does it feel like it's pushing your tooth in? Yeah, or it's pushing up, and then relieve the area. So again, figure out which of the three things it is, the bite, the AM aligner, or the device itself, and then make the adjustments. Don't just always assume it's the device itself. And also keep in mind what Rich already said. The forces on the teeth is going to push back on the upper, pull on the lower, so it's probably putting too much pressure on the buccal of the uppers, linguals of the lowers, as you use your brains a little bit to adjust this. I think most people can figure that out if given enough time. If you'll just break it down into those three categories. Rich, I've had some challenges with this. I've had to maybe adjust the way the device hits because I had a patient, it's actually a friend of mine, had some periodontally challenged teeth, and those were hurting. So we had to redirect the forces to other teeth by subtracting and adding acrylic. But I can knock on wood, I can't ever remember that tooth soreness was a reason that a patient said, I can't continue to wear this device. I mean, if it's happened, it hasn't happened enough that my old brain can even remember. So it's something I think we can almost always overcome. Would you agree with that?
I would. But again, I like the point that it's not always the device. Sometimes it's the way that happens. And we had some people with questions and things like that using pressure indicating pace and using, again, that's just using your brain. Most of you dentists are very good at figuring out that kind of stuff. And remember, a sleep device, we don't want it to be an orthodontic device. It just wants to fit the teeth like a really, really good retainer. I think that's the best way to talk about doing it.
Yeah, and I think one thing I don't think we mentioned on here, which may be the most important thing we'll say altogether, is I tell every patient your teeth are going to be sore. And that's one of the reasons I don't see patients for about 3 weeks. I say they're going to be sore all over. If it's something you can deal with, it goes away in a few minutes, then each morning, don't worry about it. If it continues on, or if you can't wear the device for any reason, you call me and come in. And having set that expectation at the delivery oftentimes get you through this too. If they think it's not normal, then they're going to call you. Most of the time, given it time, you'll get right through it. So some of you came on a little bit later. We got a lot of people on here tonight. If you are interested in learning more of the hands-on 2-day courses, just type in course and you can see a few dates here. We're adding more as well. And you can receive $200 off our low price of $795. So that's for you and a team member. You get a dental device and a home sleep test, which is worth the $795 in and of itself. Custom-made device from one of our partner labs. So remember that. And again, if you want more help while doing this in your offices, this is what we do. I'm confident there's no other company that does what we do. Our goal is to help dentists help their patients with dental sleep apnea and snoring and sleep disorder breathing. And that's what we get up every morning doing. And if you have questions or you want us to answer specific concerns, or you just like to talk about our services, type in consultation, and one of our trainers will sit down with you and answer your questions and get into more detail about anything that we talked about tonight, or any of the other dental sleep topics. So please, if you're more interested, type that in. All right, jaw pain. I think this is one of the three that we say we see the most. And I think the first part of this, Rich, is I strangely enough, this kind of stuff actually doesn't stress me. It's almost good for the brain. It's almost like a puzzle. You start trying to dissect where it is. When is it hurting? Is it night or morning? We got to go back to those same things. Is it one side or both sides, the joint or the muscle? And I think it's almost it's like doing a crossword puzzle or something, or some sort of a puzzle, because you're just trying to figure out each of these. And that's what you've got to ask yourself, these questions. And once you go through those questions, the answer, at least of where the problem is and what type of problem it becomes pretty obvious when you ask the questions that we have here on the screen.
Yeah, when, which side, where, I think you really have to kind of figure out, guys, that a muscle or a joint issue. That's kind of the way I look at it. But when you say when, here's an interesting case that kind of drives the point home that we have to use our brain. We had somebody kind of a class 2. They seem to function a little bit more forward. Their natural bite was class 2, but they moved a little forward. We put them in a device. We start moving them out. 4 or 5 weeks into treatment, their jaw starts hurting. Well, when does it hurt? Well, when I take my device out, does it hurt then? No, it doesn't hurt until I put that AM aligner you made me. When I put the AM aligner and I force my bite back, that's when it kills me. All right, well, why don't we quit doing that?
Or waiting until later on in the day, or doing it more gingerly, slowly. But what I think you want to emphasize on this, Rich, because it's going back to the tooth pain and so forth, they're not going to come in and tell you that unless you ask those questions. They're not going to come in and say, my jaw hurts when I take it out. It feels great, and I put the AM aligner in. That's when it hurts, doctor. They're never going to say that. They're just going to come in and say, my jaw hurts. And that's what they're going to say. And then you've got to do the detective work, which I said is kind of interesting. You ask the questions, when is it? Where does it hurt? And if they point to a specific spot, it's a lot of times the joint. If they put their hand on the side of their face like this, then it's typically a muscle, which is more common than the joint anyway. And then which is it, one side or both sides? So we'll go through some more specifics on this, but it's asking these questions that'll get you where it is. So we ask the questions and we find out that it is on both sides. Okay, and is it what is the typical most common causes of these? We have them listed here. You've gone too far too fast. That's by far the most common. We've just got in a hurry to make them turn into Jay Leno here or something, where we can get the airway open, but we can take our time, folks. You don't have to do it overnight. And it's just that newness and stretching. And I would say the second most common is the too aggressive AM aligner placement in the morning. They're really worried about their bite. The person's following all the instructions, and they're going to get their jaw to go back in 0.2 seconds the moment they take the mandibular advancement device out. And that can, we still want them to go back, but we can do that slower, have them wait a little while, have them do it with less force, have them do it slowly over time, and maybe take it 20 minutes to this instead of trying to get it accomplished in 1 minute. So this is your patient, Rich. Is that too far, too fast? You titrated him that far the first day, did you?
Yeah. That actually, his range of motion was 10 millimeters, which is pretty normal. He was a class 2 bite, believe it or not. That was back in the old days before we had the hook system for the taps. We had to cut the plate off and move it, every single time. But this guy's at 27 millimeters now. And it took us 2 years to get him out there. He was just bound and determined that he was not going to go back to CPAP. And, that's kind of a weird person that would be this compliant and this motivated to do this, but it did work well. So I don't know what is too far, Guy. Again, the key there is it took us 2 years to do that. So when both
go ahead.
No, when both sides are hurting, almost always we've gone too far too fast, you know, so we want to back up and slow down. Remember, you can turn the screw the other way. You can change the connecting rod. You can use a different rubber band. You don't always have to go forward. I think this is a much bigger problem, Guy, for people who take bites at 60 or 70%. Right. I typically take a bite at about 30%. And I know some of you are going, what? You know, if I've learned anything, Guy, over the years, it's go slowly. Go slowly. This, you taught me, it's the first lap of a marathon. This is not a sprint. You know, it's going to take us a little while to get this thing dialed in, and we're going to do it, and we're going to do it well. So, you know, back up, slow down. People forget about the back up part, you know. So if you start them at 70% and you only had a half a millimeter, yeah, it's hard to back up. You got to, maybe on your Herbst, you could go to a shorter arm, you know, you might have to take a new bite, reset it, and do all that stuff. But all of these other things make a difference. They really do.
And the last one on there, take a hiatus from the device. Hopefully they'll wear a CPAP or something. Obviously there's complications. We can't just say don't wear your device when you have an AHI of 75 and just had a heart attack. We need to use our brains and our judgment. But if that's a possibility, taking time off will oftentimes help. And then lets the muscle heal, lets the areas heal, and now we can come back in. If you go to the gym every day and you pulled your muscle, it's harder to get that muscle to heal while you keep going to the gym. So bilateral pain, we can turn the screw back, use shorter bands for the EMA. We can back up the screw if you run out of room there. If the wing's thick enough, you can shave a little bit off, and then we can use different arms on the Herbst. But Rich has got the best point. I'd probably typically go 40 to 50%, but you know, the bottom line is you can't always move these back. And so if you find yourself in that situation and you feel like you've gone too far too fast and you've gone back as far as you can, then you can retake the bite, send it back to the lab, and they can reposition it at a more retruded position, and you can start the process over. And I have had dozens, I would say even hundreds of patients that we've had, easily hundreds that have had this problem, that we've backed them up, slowed down, taken the device out for a while, and they've done just great over time, and they're still wearing the device many years later. So that's primarily muscle. It can be when it's bilateral joint. It can be capsulitis as well, which is you know, not as common as the muscle. The most common thing I think in the joint problem might be some unequal posterior stops. The tap device I love. But if you get one side hitting and not the other, or it either needs to hit on both or neither. I think that's true for most devices. We want it to hit all the way across the front, or we don't, and not in the back or all the way around, or at least bilaterally on the posterior. So you can add stops to these using thermocryl, self-cured acrylic, if you want to decrease the pressure on the joint. If the joint is actually hurting bilaterally, and you have a tap device, and what happens there is when you clinch, it might be fulcruming across the front and putting pressure on the joint. Kind of
doing that, making the jaw do that a little bit.
Doing that, and that's where the pressure goes. Once you get something in the back, when those muscles are activated, it's not going to, not going to cause that TMJ, the joint itself, to be seated as firmly. It's got something to resist against, and it can take the pressure off the joint. So bilateral joint discomfort is typically that we want to take pressure off the joint if possible, and it can be too far too fast as well. Anything else I missed on that, Rich, that you want to add?
No, I think that was good.
I think this is an important part of our exam, and I have to say sometimes I've missed this, get in a rush. If your patient goes one side, deflects, or deviates, goes over and comes back, this means they have an internal joint problem typically, which doesn't mean a whole lot about a lot of people think we can't treat these patients. We certainly can, but we need to know that that's going to happen. And if we have a device that's hitting on one side and not the other, we need to accommodate that shift so that we can turn a screw on one side a little bit more than the other. So I think we've hit muscle pain. I'm gonna move on to unilateral in a second. I think we hit most of these. I think the Deprogrammer is the one we're going to talk about in a minute. In addition to, I think, NSAIDs, which are huge. Anything on this page you want to touch on, Rich, before we move on?
I don't know if we have muscle relaxers on there, Guy. I
We
got
do.
my
I think
question thing open.
there you go.
Yeah.
There you go.
So there they are. Remember, these are short term. You guys take a picture of this with your phone. Have your office manager tomorrow type it up on a little card for you and just keep it in your, I don't even prescribe these things enough, or I can even remember this half the time, Guy, because we only do this once every couple weeks, and I'm making 75 devices a month. So we don't use this that often, but remember, these are short term, 10 days at the most. Be careful how you do it. But
if it's muscle pain, absolutely, we want to get that muscle calmed down. And I think I'm probably one of the biggest believer in these NSAIDs. If you, in conjunction or instead of, you want to give someone the non-steroidal anti-inflammatory drugs, they can really help both capsulitis and the muscles heal. I mean, these aren't just pain medications, as most of you know. They actually help the bodies heal, and you got to give a higher dose. You got to give with the ibuprofen 800 milligrams, and you can give a prescription for that, or you can tell them just take over the counter with a Aleve or an naproxen sodium. You got to give really double the over-the-counter dose. What I've gotten to do, Rich, most of the time now is my friend Ed Zevovich told me about. He uses this Melexicam, and it's just once a day. And what I like about that is they go to the drugstore.
Easier to remember.
Easier to remember, because I tell you, I had that knee problem, and I was using ibuprofen 3 times a day, and I'd forget. I'd get 8 hours to go by.
You'd forget when your knees start hurting, wouldn't you?
Yeah, eating in. Oh, no wonder it's hurting. I'm 10 hours. I should have taken one 2 hours ago. So write that down as you're writing things down. It's a once a day anti-inflammatory, and it really we don't want to keep these people on this for the rest of their lives, but a couple of weeks a dose of this can really decrease the inflammation and get that discomfort back to where now they're happy. We back them up, give them anti-inflammatories, give them muscle relaxers, moist heat, and if that doesn't do everything, or if we do all this, we take them off the device and we bring them back, and they're still just clenching and their muscles hurt. A lot of times it's the masseter. One of the most common areas is right at the attachment, inferior insertion of the masseter. They'll say it hurts right here on both sides. What you can do is add a deprogrammer. We just add a spot in the front to where it doesn't hit in the back at all. And this is going to, at the very least, move the fulcrum forward so that we're further away from the joint. And we can decrease the amount of muscle activity. I'll go through these very quickly for time. You just do this in the office, and your team member can do this in about 15 minutes. You roughen up the acrylic. You make you a blob of acrylic. Put it on there. Don't do what I learned at once and get the acrylic inside the tooth, and where the teeth are. Get a little down in there, and then it doesn't seat, and that's disappointing. I figured that one out along the way. Make this blob of acrylic in the front. I like putting it in these pressure pots. I have this middle one here. I think that's around a couple $100. I put that in the sink because it goes everywhere when you pull it, because you got to get it really full. I use a little warm water if it's not thermocryl, so it'll seat more. Throw it in there, tighten it down, try to get it up to about 30 so we don't have as many voids in it. Comes out looking like that. We smooth it down. And the key thing I want to show here is you don't want it to hit in the back. You're defeating the whole purpose if you put this on and it's still touching back here. So you want to make it thick enough that when you're done, it doesn't hit, but then you can grind it down to where you have as small a space as possible, 0.5 millimeter, maybe 1 millimeter, and you want it to hit evenly. So this is not acceptable here. We want to make sure it goes and hits a little more evenly across there. And I know, Rich, you have a trick here that you like better. You can explain kind of quickly if you can, that I think is really cool idea.
Same thing. I don't, we typically put them on top. I'm not sure why we did this particular one on the bottom, but, we actually, if this doesn't get the jaw to calm down and do that, we actually turn it into an NTI. We just mark the midlines. We do that. We grind a hole opposite edge of where we put the acrylic, and we just turn it into an NTI. And I just wanted to hit the lower 2 teeth or the upper 2 teeth. Again, not hitting in the back, keep the vertical as closed as we can get it. And
you got smart here. You put some wax in here so that doesn't go through. Okay, so maybe I should have talked to you before I got the acrylic on the inside. So that's to keep that from going through that. Huh?
Yeah, keep it from, getting in there around the teeth because it's really hard to see, if you
Yeah,
do
it's
that.
really,
And then, when we do that, we're just doing that kind of thing. And yeah, you'd be amazed at how often that works really well. I did have a dentist tell me the other day, guy in a course that I was doing, he said he uses the composite. He gets, some of his old composite that's about to expire or something,
yeah,
and
sure.
he puts it on there as well. So there's a bunch of different ways you can do this.
And the goal is to hit just in the front. It works like a deprogrammer NTI. We can't go into an hour and a half discussion about that, but in many cases, it can decrease the amount of muscles they're going to fire. So if they can't fire as many muscles, not clenching as hard, their muscles will calm down. So it's a great thing. And also it's a good way to prevent devices from breaking sometimes too, because you move that force more forward and they can't put as much force. I like the little window. I think it helps with proprioception because it's hitting the bottom teeth is what your goal there is instead of acrylic on the bottom. Is that the point of that? I think.
Yep.
Okay. Well, what about when it only hits on one side? I actually think this is sometimes easier because we kind of can rule. We know that most of the time something's amuck here. Something's hitting hard on one side. The wings catching sooner on one side. We've got a occlusion problem. They have a deflection that we didn't notice, and something's catching. So just remember, when it's just on one side, most likely something's not even. Something is asymmetry in what it is. And the biggest cause I have for this is this one. If they take the bite and they're off to the side, when you take the bite, you don't notice it, and you make the appliance over there, and that's not a comfortable position for them, then they're going to have pain on one side and possibly not the other. This happens. Your patients they tweak the device on one side more than the other, or they put, like here, this patient's got a 20 on one side and a 21 on another. Man, I can tell you, these patients come in, you got a dorsal and they've turned it 25 turns on one side and 5 on the other. That now the jaw's hurting. It's very common. That being said, if they have a deflection, sometimes we want to do that so that we keep
That's a
up
good
with that.
point. That's a very good point.
So
Sometimes we want to do that. Just make sure you make a good note,
right.
when you do that, so the next time they come in, you don't line them back up in the center again or something like that. I always think, Guy, too, when we're looking at a dorsal and we're hitting in the back, the side that's hitting first is the side that's going to be hurting. That's how I always remember it. So when you put your paper in there and you mark it and that kind of thing, almost always. So, when we go to do that on a dorsal, it's always easier to adjust the top. We buy at the dollar store little pieces of sandpaper, and we just go back on the counter and we stick them on the corner and we just, rub that side. So it's, you're not taking a burr. It's very hard to take a burr and make it perfectly flat like that. With the sandpaper, we just run it on that sandpaper like that and then polish it up a little bit.
So that's medical grade sandpaper we're using, right?
Of course.
Okay.
Sold at the dollar store.
I have the picture in my head just perfect. I know exactly what's going on there. Yeah, he's got his belt sander out there, from DeWalt belt sander. All right, but the side that hurts is the side that you're going to adjust. And articulating paper, we don't get out in the office very often. I mean, look in there. Where's it hurting? It can be the wings too, or the herpes bar. One side can be catching, and then it's pushing the jaw over. If they got one of the rams on this side's catching and then this side's not, then the jaw will catch up and go this way, and they're consistently torquing. So look at the way it hits this way, but then also look at the mechanisms to see if they're catching at the same time.
Yeah, that's a good point too, Guy. With the mechanisms on the herpes, we saw one the other day because the patient had a posterior crossbite, and it just wasn't moving well enough. The male female portion of that was catching, so they weren't the same. Then again, that comes back to using your brain.
Yeah, just remember, unilateral, something's not either hitting right this way or with the mechanism holding up or one side hitting more than the other. The vast majority of the time, that's the cause, and once you find that out, you can readily address the problem. So in summary, managing TMJ and muscle pain, decreased muscle function with the programmer, hitting evenly if it's unilateral, decreasing the muscle by making the NTI things, and now if the joint's hurting, then you want to support the back side. So you want to make sure you're adding in the back so it's hitting evenly. Muscle relaxants, NSAIDs, and backing up the device and going slowly forward is the key. We're going to touch on too loose, and then we'll have some time for some questions. I think this is my son's picture here. Probably I've done a few years. He's 12. But this too loose thing, I think this is. We have it under side effects, but I think it's important enough for too tight or too loose that we can just talk about it, because it's one of the most common. It's really not a side effect, but it's something people are challenged with. And if it's too loose, it's moving, and then the patient gets soreness and different things. And so for the longest time, I couldn't adjust these ball clasps. I couldn't figure out what to do. So dig out those old spoon excavators that you probably already threw away. Those are fantastic for bending those ball clasps over. You can reline your devices if they're too loose. You can add acrylic. I hardly ever do that. You can do it and use the pressure pot. But I really tell you, Rich, you taught me this. You can take your device, you can heat it up one quadrant at a time. You can do it with a torch, or you can do it by putting it that side in hot water. How long? Well, experiment. Put it in there for a little bit. If that's not enough, put it in more. And then you take it, and while it's hot, you squeeze the buccal and lingual together. And I usually have either a bowl of cold water right there, or I have the faucet running right beside me. While it's hot, stick it under the faucet. And I can tell you that's
while you're squeezing it.
While you're squeezing it, and depending on how thick the device is, as hard as you can to, you got to kind of figure it out over time. And you can take a device that's falling out, and in a matter of 2 minutes, heat up both sides, squeeze the buccal and lingual together, and lo and behold, now you put it in, it pops in, the patient thinks you're a genius. So it's really probably one of the most time-saving things that I've ever come across. And then these things, these Hilliard pliers, work fantastic for EMAs, but you can even use them on something like a Narval, or even some of the full acrylic devices. You heat up this plunger, so you heat up the male portion of that. You can see there's a little slot it goes in, and then all you do is just squeeze it into the interproximal areas. I think the next picture shows it better, and it puts a little dimple in between the teeth. And that, like I said, for EMAs, the Pantheras, now we don't make Narvals, but this is a Narval Pantheras. These work very well, and even some acrylic devices, we can get that to fit much tighter when you get something like this. The same principles work if they're too tight. So if the patient says it's just tight, or I can't take it in and out, my teeth are hurting from taking it in and out, then what do? You go and you take the one side of it at a time, put it in the hot water, or you can put the whole thing if it's tied all the way around, put it in. Oh, it's looser now. Take it in and out, take it in and out while it's cooler, and put it and then cool it down. And a lot of times that'll make it fit a lot looser. Even if it's an all acrylic device, it doesn't have to be thermocryl. That works real well. So anything else on those subjects, Rich, to add?
Yeah, I would say, if you got to experiment, you got to be careful. So, err on the side of not quite hot enough, squeeze, right. You know what I mean? You get a EMA too tight and you squeeze real hard, pretty soon you go, oh man, well, you ruined it. Right. So, but you can even do that with acrylic devices. If you get that water boiling hot, you put a quadrant in there, and we kind of made an adapter to a pair of pliers, guy, that has kind of longer beaks on it, and you get it real hot, you put the plier on, and as you squeeze, I'm literally moving it right underneath the cold water. And if you squeeze hard enough, it will crack, and then you'll know you squeezed too hard.
Well, then you'll know where too much is, right? But let's hope you don't get there. It does work, so hopefully these things can help you. I think that the key is the way we started this webinar is that the way you handle and manage you and your team, the way you react to these side effects that you're going to have, accept it going into it, is more important than any particular technique or advice that we've dispensed today or might dispense in the future. You just got to be confident and let them know this is normal. We're going to hold your hand through this. We're going to help you get through this. Wearing this device is really important. It's important for your well-being as far as how you feel and function, and your spouse's function probably, but also for your health. So this is important. We're going to work with you, and just don't act like you're that surprised. Don't minimize it. I'm not saying that, but just act, we're here to hold you, your hand, and we're going to get through this with you. And I think if you start out that way, and then when they have these problems, you have that demeanor, All these other things we taught you, you can figure it out without our help. Having that demeanor is really, the patients will pick up on that, and you'll take off and love doing dental sleep, because these things happen, but not so much as the balance of what is enjoyable out of dental sleep as far excels these things that we've gone over tonight.
I love that picture of that kid there, guy.
I think you found that. I don't know, but we just got to stay together and get through this. Now, almost as enjoyable of a topic is out-of-network billing that we'll be going over October 9th. So if you got an email for this webinar, you'll get one for the next one. It's more specifically, if you don't have contracts with insurance companies that are not in network with Medicare, how do we maneuver around that when we don't know the allowables? And we've done this more than once, but you know what? It's changed since then too. This will be different than the last time we did it. So stay tuned. If you want help with dental sleep solutions, our DS3, we have what we call a 360 solution. It's everything from helping you screen your patients to getting them tested, all the steps for treating we can help you with, and then billing. So you want to get paid for doing this. And it's nothing that is that complicated to where you have to have all these great skills and talents, but you have to have systems, and that's what we provide. If you don't want to recreate the wheel, let us know how we can help you. The Insider, I think, is coming out soon. I just saw the draft of it today. I didn't even get to look at it yet. Rich, what did you do on this one?
Another fantastic one where we talk about sleep testing. Man, I just can't believe our team just pumps these magazines out, and we're getting so many different contributors now, but man, our staff does such a fabulous job, doing this. I talked about getting out of your comfort zone, Guy, and how it's limiting, our success in sleep. So I think it's a pretty good article, but there's a lot of good stuff in these things, and we don't even charge you for it, man. It's free. You just sign up for it. It's just another thing.
It comes in your inbox. Very, very practical thing. So if you're not already getting that, go to www.dentalsleepinsider.com, and you can actually view all the past issues. I think I know we're over 24 issues we've done, and you can look at all of them. And a lot of the things we've talked about are in there. Again, Rich and the two legends in dental sleep, Dr. Rich Drake and Keith Thornton, are going to spend, 2.5 days with you? Is it going to be, I think, right?
Yeah, Thursday evening, and then Friday and Saturday, till late afternoon. Guy, there is one question about going back to the muscle relaxer.
Sure.
By the way, if we're going to limit that. We are going to do more than just this one course, but I think we're going to limit it to just 20 or 25 dentists like that. I think we're getting close to that already. So if you're serious about that, look into it.
Yeah, I can put up the muscle relaxer slide again in a minute. So again, if you want to come to this, and I think that's our contact information. So let me see if I can do that. What other questions are on there, Rich? Are you looking to make sure we got all that?
I think we've done a pretty good job. Somebody mentioned the Medrol dose pack. If we get a lot of information, because you talked about the meloxicam that you like, Guy, which I am a big fan of as well. And the Medrol dose pack is I have pulled that out of my back pocket a few times. Okay. And it does. I mean, it's great at decreasing the inflammation. So I think keep it in your pocket. I wouldn't go straight to that without doing some of the other things that we talked about first, because most of the time these things calm down and they do well. Right. But remember, if the patient is an itis patient, that's what we call them, Guy. They've got anything from fibromyalgia to rheumatoid arthritis to psoriatic arthritis to whatever. They got some kind of itis going on, that especially if they're on some of the biologic tissue necrosing factor infusions, those people tend to have much more inflammation going on all the time. So I would say probably half the time I've used a Medrol dose pack has been on somebody who's been on one of those infusion type of drugs like Enbrel, Remicade, Humira, some of those types of things. But keep it in your pocket, absolutely.
We got someone that wants to see the Dallas information again, so I'll put that back up. Hang on. There we go. All right, look at that. All right. Yeah, that's going to be a great course. Keith Thornton and Rich, I think between the two of you have been doing this, well, I guess probably pushing 50 years or 45 anyway, between the two of them. It's going to be, I mean, there is an agenda. I've been privy to some of the planning of it, even though I won't personally be there. But I think there's also going to be a fair amount of room for personalized interaction. I think it's what the goal there is too, right?
Yeah, everybody that we know, Guy, everybody that comes to a course has 3 or 4 or 5 questions that they want to get answered. And, these types of courses where we limit them, and we're doing an awful lot of hands-on stuff in this course. We're going to do a lot of hands-on stuff. So I think you'll come away much more confident and much more competent in how to treat some of these patients.
Yeah, and what Mark Fowler brings to this is I've been personally working with him for quite some time now, and the world's changing. We don't rely on all the physicians sending me the patients. We don't rely on the screening and testing for everything. And where do people go for information? They go to the internet, and Mark Fowler will teach you how to optimize your visibility and exposure on the internet, how to basically market your practice, set it out as we do dental sleep in our office, and it'll help you understand some of the things I didn't understand before about websites, pay-per-click, social media, and so I think that'll be great to be able to sit with him and listen to what he has to say, and then be able to ask any question you want. I think it's extremely valuable, because this is really to help dentists take their practice to the next level. And we want to be clinically confident, but then we also need the patients coming in as well. So that's why we're bringing Mark in to help fill in that part of it. So do we get through all the questions here? I see our team, as usual, has done a fantastic job. Adding acrylic.
Well, absolutely, Dr. Doran. The vertical is always an issue. Always, always, always. When you think about what I have control over as the dentist is the vertical and somewhat the protrusive, because we give the patient the key. They can adjust it if they want. So, in general, the less vertical you have, the more comfortable it is. Now, the only study I know of that's been done is Todd's last name.
I don't remember. We did it on the tab.
I'm drawing a blank.
Yeah.
But when we look at that, it only had an N of like 15 or 20, something like that. But it said that males benefited a little bit by more vertical, and the females were about the same. What I think, from my experience after making 50 to 100 of these things a month for almost 20 years now, is big tongues. I can't breathe through my nose as well. I tend to add a little more vertical. To me, it's not a whole lot more complicated than that. The more TMJ problems and issues they have, the less vertical I usually want to add. So yes, you have to be careful when you're going to do a deprogrammer about adding too much vertical. I think that's what got me into drilling the hole in the teeth, Guy. I was able to close it down just a little bit more as well too. And then again, we use the medical grade sandpaper in the back to thin it out a little bit. But yeah, you do have to be careful, and you got to use your brain. That's a very good point.
Okay, I'll get the grit from that from you later. But so I want to add that we used the tap ones for many years with the hook sticking out. Many of the studies validating that these devices work were done with the tap one, which opens up the vertical. There's no way in the world you're going to get your lips around this unless you like to do like a lollipop. And those patients were highly successful by the study. So is it ideal in some situations? No, use your brain. But, if the number one thing we want our patients to do, we have a 3-step process for every patient. Once we give them a device, you know what's number one?
Can I guess?
Yeah, go ahead.
You got to wear it.
You got to wear it. And if their jaw's hurting and their muscles are hurting because they're clenching or this thing's breaking, then I'm not going to worry about the vertical and the lip closure, because if we don't address that, we're not going to get them to wear it. Now, granted, we did all these other things first. We backed it up. We slowed down. We did NSAIDs. We did some of that. First of all, I don't want to take our team's time to add that if we don't have have to. But by the time we add that vertical stop, we've exhausted our other options. And if they're not going to wear it, then this is useless anyway. So adding that becomes very obvious is the right step to do. And many times they do well. Now, one thing I will mention is if we've already sleep tested them, then we may need to do another titration study because that could affect things. That's why we do the 3 steps. Wear it comfortably. We address their symptoms, number 2, and then we test them. If you get in too big a hurry to test someone, then you're going to have to go back and retest them if you went and open up the vertical, because it can certainly change things, maybe for the better, but even maybe for the worse. So that would be a caution I would have. So good question. So well, I think this has been good, Rich. We had pushing a few hundred people on here tonight. I saw one questioner, this is recorded. So if you want to ever see this again, it'll be on YouTube. And we have hundreds and hundreds of hours of video in our DS3 system as well. So one of the things that you have if you decide to type in consult and talk to us about how we can help you is we do private webinars every other Wednesday night. It alternates between Rich and I. We don't do them together, where we actually do open up the mics and we talk to our members, and they get to submit questions. And in addition to that, they have access to all of our private collection of training modules and our team that's available 5 days a week, Monday through Friday, to answer questions, help them with their challenges. So if you're just even remotely interested, type in consult and let someone talk to you about how any specific questions you have, but then also how we can help you ongoing. So I think that's it for the questions. Look, we ended up pretty much on time. It's 9/11 on 9/11 here. Anything else on there, Rich, we didn't get to? Because you're managing a lot of these questions.
There was one question kind of about if a patient has a little protrusive movement, can the ligaments be, I'm guessing that is elongated. So, I mean, we can absolutely increase a patient's range of motion in their jaw. Absolutely. Just like a physical therapist can do with stretching your leg or your knee after surgery or anything like that. So, yeah, we can. And remember, that might be something that you want to do on somebody who has very, very little protrusive movement at all, and they're very, very tight. Occasionally, we will put them in an NTI type device and on NSAIDs and even maybe a muscle relaxer, just to get them to where they relax enough to where we can take scans on their teeth and take a bite. So it's a good point. Right. Thank you, Guy, for putting that thing together, man. As always, you did a great job doing that. Thanks to our team. Thank you guys for joining us for part of your Tuesday evening.
Yeah, in October, I think it was the 8th, we'll have another night when we're talking about the exciting world of out-of-network medical billing. So don't miss that. It's if you think this was exciting, wait till you to talk about out-of-network medical billing. No, truthfully, it's a type of presentation you probably won't see most places, because we'll try to get through how you manage that. So thanks again, everyone. Good luck to everyone on the East Coast. That hope hurricane somehow slows down, and let us know if we can help you if any of your dental sleep needs. All right, good night. Good night, Rich.
Thank you, guys. Good night, Guy. Have a good evening.
You too.